I would like to start by acknowledging the traditional custodians of the lands on which we meet today. I'm on Wurundjeri land in Melbourne, in Naarm, and we pay our profound respects to elders past and present. We celebrate the stories, culture, wisdom, and traditions of Aboriginal and Torres Strait Islander people and thank them, the people who are part of ABLE's network and community, for the valuable contribution they make to the lives of our people, our environments, our communities, and our work. Always was and always will be Aboriginal land. So ABLE is hosting today's session. So we are the national peer-led peak organisation representing the network of peer-based state and territory drug user organisations. Our work is informed by the amazing people who use drugs and who for almost 4 decades, if not more, have been striving for equity and social justice in the face of criminalisation. We're committed to working alongside our community of people who use drugs, challenging stigma and discrimination in all their manifestations. So, just to reiterate one more time, if you have questions today, please use the Q&A function to type your questions for the speakers and we will try and get to them. So our speakers today are Dr. Tim with an unpronounceable last name, so that's why we affectionately call him Dr. Tim, and Sonia Wee. So Dr. Tim's a peer researcher at Griffith University in the School of Applied Psychology and the Centre for Mental Health. He's also a director of Quiver, which is the Queensland member organisation of ABLE. So Tim's going to be discussing performance and image enhancing drugs, giving us more information about who uses them, why people use them, and giving information about what kinds of advice that we can give people who use our needle syringe programs and services in terms of harm reduction information for people who use performance and image enhancing drugs. And Sonia Wee, who is also speaking today, is currently studying a Bachelor of Social Work and doing a student placement at Quiver. She also works in the sector, and she also has lived experience of using performance enhancing drugs. So she'll be using her experience throughout this session, as well as in her work and life, to increase knowledge and understanding for other women who have experience of using these substances. She is passionate about social justice and advocacy, and we are incredibly excited to have both these speakers here today. So take it away, Tim.
Thanks for having me. And it's so great to be here, so great to have this webinar and have this national focus on performance and image enhancing drugs. And so today, just want to present a little bit on, I guess, upskilling everyone's understanding and then how we respond. And this is particularly targeted at health workers, health and harm reduction workers, so particularly people at needle and syringe programs and any sort of wraparound service there, as well as peer workers who are interested in upskilling in this space. Similar principles will apply, and there's knowledge that can be gained for healthcare providers, medical professionals, and scholars and academics as well. So also just want to acknowledge the custodians of the land, the traditional owners of this country, and pay my respect to elders past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander people. Also want to recognise the bravery of the peers that have enabled discussions like today to be able to happen, to be able to facilitate these open discussions on harm reduction and health enhancement, and very, very grateful to be able to do that. When we talk about performance and image enhancing drugs, most people jump to steroids. And so even myself, just usually say steroids because it's a lot easier, a lot more accessible, makes more sense. So in terms of steroids then, these drugs, and we'll get into a bit more nitty gritty, But these drugs are used by about 3.3% of people globally. They're used for aesthetic reasons. They're used for performance enhancement reasons. They're used for well-being, feeling youthful, and things like that, as well as general mental health, anti-aging, so on and so forth. And they're used by a variety of different people. So you see influencers like Sam Sulek there, flexing his pec major really, really hard, and looking huge. Same with, I guess, the people across the bottom. Everyone here is using steroids, but they don't necessarily have to look like Sam. They can be your next door neighbor. They could be someone at the institution you're working at. They could be anywhere. And so I guess the way that we consider the material practices of the people using these drugs needs to change and needs to be reoriented. It's no longer the hardcore, Arnold Schwarzenegger's, people winning the Mr. O, things like that. It's people around. And so I'm sure I'm preaching to the converted here, but again, the people you will see in the workplace, the people that you will see accessing your service, could be across this spectrum anywhere. I will mention that these drugs are associated with physical and psychosocial risks, so things like hypertension, reproductive issues, if you're injecting them, bloodborne viruses and infections. We'll get onto that more later. But there's also psychosocial risks, so things like depression, things like mood changes, and changes in, I guess, emotional regulation or dysregulation. And so why are these drugs getting attention? Why are they important now? They've always been important, but I guess I've got some nice statistics to present to you on our situation here in Australia and in Queensland. So over the last decade, from about 2011 to 2021, we've seen an increase of almost 1,400% of the weight of the steroids being seized. So about 500 kilograms now from 30 kilograms in the past. Huge. In a similar way, we've seen an increase in arrest rates. So we have about 218% increase across that same period to a record of about 1,300 people being arrested every year. Consumer arrests continue to account for the largest proportion, so the end user, and that's about 82% of those. So people in community who are using these drugs for whatever reason, are disproportionately targeted. And so they're subject to this hostile environment. And it's really, really important for us to be able to provide some level of response. And I guess it offers us a beautiful space to be able to engage and provide some level of safety and solidarity. At NSPs in Queensland, we've been looking at some data from the NSP programs as well as Quinn. Just like to thank Professor Jason Ferris for doing some of this for me. Sorry, doing all of this for me, actually, as well as the people from these services that have given us the data. Across Queensland, and I'm going to hazard a guess that there's similar trends across other states and territories, particularly along our east coast and across parts of our west coast. We've seen about 10% of people accessing NSPs are using or accessing them for this reason, for these service occasions. At Quinn, interestingly enough, it's almost 1 in 5 people. It's really, really getting up there. And so we saw a lull around COVID for a variety of reasons, but there's definitely been, things have picked back up. And so as things pick back up, I guess, this is another reason for us to consider what we can do to offer that safety and solidarity for this group. A few other, I guess, important things from this data that I wanted to point out that we have across 2016 to 2023 is that highest access group is that 16 to 29 age bracket, that we have high levels of access in metropolitan areas, but we have some more uptick in regional areas as well. And so really, really important to consider those, I guess, people in perhaps regional, but then also rural and remote communities, and how we might ensure their safety and ensure that they have enough injecting equipment and things like that, or how we can get that information that they need further out. Just trying to paint you a bit of a picture here. So the other things that have sort of been going on for some time is that our traditional responses to injecting drugs or harm reduction to drugs have really focused on intravenous drug use and drugs outside of intramuscular or subcutaneous injection for obvious reasons. The lack of health service access that we've seen among places like general practice clinics or healthcare clinics, pharmacies, places like that, predominantly due to stigmatization and perceived lack of knowledge. I'll note that in terms of NSPs or any sort of harm reduction services, that's not quite the same. And people who use these drugs actually report more positive experiences. They're also really, really interested in being there. And the real, I think it's pretty obvious. The real reason is that I guess NSPs have something to offer you if you're injecting drugs, and that is the equipment. But we can really transform that occasion of service or that encounter into something far, far more valuable and something, I guess, that really extends beyond just handing over a bag. Handing over the bag, by the way, is absolutely fantastic, and it's already doing so much good. But just looking at how much more we can do. The harms that I spoke about earlier related to steroids and these other drugs are there and to be acknowledged. But I think what really potentiates these harms is the underground, unregulated and illicit market that we have. And because we are subject to a punitive and a criminalized environment, particularly for steroids as well, we need to consider that, there's other risks as well in that we are using, or people are using products, oils, things like that, that might have been made in all sorts of conditions under, all sorts of manufacturing processes. It's not pharmaceutical grade product. I think that's normally a given, but it's been left out of these discussions up until recently, and it's a really important part of these discussions, and I'll tell you why soon. So that's the sort of picture of the landscape at the moment, and taking that picture and moving forward, I want to give everyone a bit more information about steroids and other performance image-enhancing drugs. So there's a base level of knowledge there. And I want to give you some ideas of how they're used so that we can upskill the knowing. And I want to give you some ideas on how we can respond and give you some resources to that as well. And then the wonderful and amazing Sonia has agreed to come on board and speak about a rising prevalence space, and that is the use of these substances among women and what we can do. So I said steroids earlier. Actually, we've got a vast variety of compounds, about 32 documented in extant scientific literature. When we talk about steroids, we normally talk about injectable compounds. So those are the oils that are going in intramuscularly. We've got testosterone, which is naturally produced by the body, but which we can supplement with externally or exogenously. And there's a variety of different esters there. The idea of the ester in this case is that I can inject testosterone. It's attached to an ester. The ester assists in facilitating the deployment of that hormone through my body across a specific period of time. So you've got shorter esters, so things like testosterone propionate, with shorter half-lives, so about 1 to 2 days. So I would need to inject it every 1 to 2 days, and people normally do. You've got longer esters like cypionate, so about 5 days of half-life, which I can probably get away with injecting about once a week. And then you've got other blends and many other esters that we won't get into. That's the general premise or idea there. I might not want to feel like a pin cushion, so I might just shoot test C once a week for a variety of reasons, but maybe I'm just sick of sticking myself. Maybe I've got a bodybuilding show coming up and I'm using a lot of compounds. I need to shoot every day or every second day, so I'm using shorter acting esters like Test P, Tren A, so on and so forth. It's a variety of other types of classes of injectable compounds, 19-nortestosterone. If you've, I guess, been following any of my work around trenbolone, you'll know that these are more potent. They have more potential and affinity for binding to the receptor, but they also, if you want to think of it like napalm, you're sort of bombing everything. And so there's other drawbacks to that and lots of other side effects that can come. Similarly for nandrolone, but not as many psychosocial effects from what I understand. DHT derivatives, things like drostanolone, methanolone, these are also quite often used alongside testosterone. And then you've got oral compounds. Oral compounds, high strain on the liver, so they have to make a double pass through. The only exception to that is down the bottom there, misterolone or proviron, but it's super mild, not generally used in like an active cycle or usage phase. It's more of like a bridge, and I can talk to that a bit later if you want. But all of these other beautiful tablets or liquids are generally sort of used alongside injectables, but there's a few caveats there, particularly for women who use oxandrolone, and I'm sure Sonia can talk about that later. You've got other PIEDS or medicines that people use, so things like human growth hormone, things like insulin, super anabolic. You've got peptides, you've got prohormones, you've got other medicines being diverted like metformin to help you shuttle glucose and things like that. And I guess I'm talking about all of these to give you an idea of like the vastness of the things that people are using, just so you can start to, I guess, understand. Sometimes people also want to stop using, or they might experience some side effects while they're using. These drugs, at least in men, are the typical drugs used to either cease or bridge or restore function between cycles or post cycles. And so they're often called PCT, post-cycle therapy drugs. So things like human chorionic gonadotropin, clomiphene, tamoxifen are often used post-cycle to return I guess, production back to normal as quickly as possible. You've also got these other wonderful drugs called aromatase inhibitors, so things like arimidex or anastrozole. As you put more testosterone in, there is this conversion to estrogen that happens. As estrogen goes up, that generally comes with a number of things that people don't want when they use steroids. So water retention, mood fluctuations, so on and so forth. anastrozole can sort of nip that in the bud and prevents that conversion from occurring. Some people use it in the PCT phase, some people use it while using these drugs. So what does this actually look like in practice? Well, here's an example of a cycle from some participants from a study maybe last year or the year before. People generally will use 250 milligrams, so a mil of testosterone enanthate. They've got Arimidex, so anastrozole on hand in case of gynecomastia, so excess estrogen production leading to breast tissue growth. They'll use that for 12 weeks. 2 weeks after the last shot or pin, they will then use Nolvadex, so that's that tamoxifen, 20 milligrams a day for about 4 weeks. They'll take another 8 weeks off. That's done, then they start again. And so the basic formula is time on equals time off, and that's sort of included there. Also gets a little bit more complex. So for example, what people quite more commonly do is blast and cruise or perma-cruise or just cruise. So indefinite periods of usage from, I guess, a year to 3 years to 5 years to 10 to a lifetime. So simple example, using the test again, might blast for 16 weeks at 600 milligrams of testosterone enanthate. And this is an example from a participant again. Then they might cruise for about 4 months on 140 milligrams of testosterone enanthate. That particular person didn't feel like they needed the anastrozole. They tolerated the conversion, and so that was good for them. More complex example, maybe example 2, blasted test for 20 weeks, Monday, Wednesday, Friday, about 1 gram of it, split that with equipoise, over 1 gram of that, injected, I'm assuming, at the same time, in the same barrel across those 3 days. So as you can imagine, test E comes in usually 250 milligrams a mil, so it's 4 mils of test E going in. Boldenone normally comes in 200 milligrams a mil, so you probably got, what's that, 6 mils of body. You've got about 10 mils of oil going into your body a week. Splitting that into 3 doses starts to become necessary, and thinking about where you're going to put that is also important. Got some other examples there around using Arimidex and around using orals as well, which I'll let you read in your own time. Coming back to example 2, this person then followed a 12-week cruise and then went on to blast again, but blasted differently the second time round. So using testosterone, trenbolone, and then masteron or drostanolone as well for variety of reasons and goals. So this is the sort of picture of what people who are probably attending your services are doing. This isn't like not normal. This is all of these normal behavior. Okay, nothing to be particularly alarmed about, I would say. Obviously, there's health considerations there as well for the person, but important to understand they are informed about their use from peers and community and making these decisions for a reason. I'll come back to that point in a little while. Where things become really good and really interesting is this idea of safe injecting. I wanted to talk about how we make safe injecting matter, because a lot of these drugs are injected. Previously, and a few scholars have made, I guess, suggestions or discussions around this. We focused safe injecting around bloodborne virus prevention. This isn't a population group, and we know this from research that particularly shares needles or has a high prevalence of Hep C. What is important, on the other hand, are those infection-related risks, and the way that we communicate the infection risks and the way that we make that salient and important to this community makes all the difference. So this is from some more recent research I did looking specifically at safe injecting, and still in sort of prep, but I wanted to share a few quotes for you. They're very different risks, not the whole hepatitis. We're not sharing needles, but there's other stuff. You know, some guys are reusing pins, same pins. I'm guilty of it, done it heaps of times, probably reused one like 5 times once. It's really not good for a variety of reasons. But I guess comes back to the access, comes back to understanding, comes back to health enhancement and gains. And then around the amount of oil or the mils that you can put in and where that goes. Why am I talking about this and why is it important? We can make safe injecting matter for this community, but if we shift or transform the argument a little bit, or the suggestion, I'm going to give you 3 sort of points here that I think are really, really important before I go through some other injecting stuff. Site selection. There's different places that'll absorb different volumes, okay? So like I said, if you're shooting 10 mils across a week, you don't want to put that all in the same spot. You want to make sure that you've got a few different places to put that across. Number 1, we want to reduce the trauma to the tissue and reduce the chances of an infection occurring. Number 2, though, and the really, really important argument for this particular group is better absorption. Better absorption equals smoother hormonal balance. Smoother hormonal balance equals better gains. More muscle, more lean tissue gain, good for me. Needle size and depth. Correct size and correct depth. Again, effective drug release. Effective drug release, less hormonal fluctuations. I don't compromise my gain. And I'm going to come back to these size and depth suggestions in a moment. Aseptic techniques, so hygiene practices, vial storage. Not talking about reusing, we're talking about wanting to prevent bacterial contamination. We want to prevent infection risks. We want to make sure that you don't have interrupted training progress. If you get an infection and half your glute needs to be cut out, unfortunately, they won't look as good, or you might not be able to squat as much, or you cannot squat for a particular period of months. These are the things that matter. These are the things that need to be communicated, and the way that the message needs to be coming across. By communicating it that way, we still get the result. We still can minimize sharing if it's occurring. We can minimize reuse if it's occurring, and we can make sure that safe injecting practices are followed. And that's a strength, right, in health work and harm reduction. Those are things that everyone can rattle off quite easily and quite quickly. It's just tweaking the way that the message is coming through, or the vehicle being used to get the message across. And so for intramuscular injecting, generally barrels, needles, swabs, and a sharps container are the things that you need. People will draw up oil if it's thick through a 19 gauge. They will shoot with a 23 or a 25. So they'll swap the tip and then it'll be over. You can swab before, but you can wash with hot or warm soapy water beforehand. Swabbing after causes more bleeding. And then obviously, dispose of the needle. If the vial's kept in a dirty gym bag, also without the stopper on, also a risk of infection. So that's a good place to sort of start a harm reduction discussion there. What I did want to touch on, and I feel like this stuff's there and it's available online, and I'll point it out to you soon. What I did want to touch on is previously, and still, there's this message around 23 gauges being the only gauge to use for intramuscular injecting. Now, just want to, I guess, communicate that people subcutaneously inject testosterone, and there's clinical evidence there for about the last 7 years, showing that that's a potential delivery mechanism. So subcutaneous injection every day for smooth hormone balance is possible. I'm not saying tell people to shoot subcutaneously. What I'm saying is if you hear it happening, it's not necessarily cause for alarm. I guess the cause for alarm is if people are using illicit underground product that is, could be cooked up in whatever condition, and they're getting infections, then probably a concern. The Blue 23, if you have big glutes and big quads, great, it works. If you want to get deep into the muscle belly and have that slow hormonal release, excellent, perfect. And would recommend Blue 23, or sorry, whatever color is your state territory color for these, but the 23 gauge. However, I know that some health and harm reduction workers recently to me have communicated that people have been using 25s or 27s to get into muscles, and that was a cause for concern. It's not, depending on what muscle it is. For example, if the person's super lean, coming in to a bodybuilding prep or something, they can probably get away with the 25 in the delt or even in the quad. They could definitely get away with the 27 in lateral tricep or in pec if they wanted to. I've done it. Or in anterior delt or in rear delt. And it comes back to, I guess, how confident the person is getting the oil, backloading it in if they have to, and then being able to do that. But especially if you're running at, sub 5% body fat, there's really not much between your thin layer of low hydrated skin and the muscle sitting underneath. So I guess reframing the discussion, and I've heard this on the other end as well from the people accessing the services, if you start to immediately push back against that and say, no, that's not right, that's a disengagement immediately. Okay, so it is okay. Would I be using a 27 in my glute? Probably not. But there's definitely certain places where it's understandable. Again, depending on the site, want to get it in deep. If you're not injecting every day, if you're only shooting once a week, you want that slow hormonal release. Super, super important. Most people, though, can rotate between middle deltoid, lateral quad, so vastus lateralis, or through glute. And that's totally fine. Those are the only sites that people will use. Some people get a little bit more exotic and start to use traps and lats and calves and all kinds of things. Depends, like I said, how much oil you've got to get in. And some steps there that I sort of went through earlier. As I referred to, subcutaneous injection doesn't normally happen for the oils. Does happen for peptides, growth hormone, insulin, things like that, more commonly. So that's the other reason that these needles might be required. So 29, it's normally pretty good. Goes into the belly fat. It's normally for peptides like melanotan 2, growth hormone releasing peptides. Someone might have their own insulin that's long acting and they want to draw and inject themselves. They might have their own growth hormone that they've gotten that they break down themselves. And that's probably why they're using it. The peptides themselves usually come as freeze-dried powders, get reconstituted with bacteriostatic water, and the community's pretty across sort of using these things. If they're not, I'll refer you to a resource very soon around that. But sort of, I guess, belly fat, quite easy, quite a good spot. Anywhere where you've got subcutaneous tissue, so it could be back of tricep, could be lateral quad, could be anywhere is actually fine. It's just really easy to do there. resources that I was talking about, thanks to Quiver and High Ground, there's actually a steroid and PED section there around safer use, safer injecting. There's another special section that has resources and training, so other sort of videos, webinars, things like that, that's constantly getting updated. The other exciting thing that's on there is results from our world first steroid checking trial. We post up those results there. They're out to community. Even though, you know, samples aren't individually analyzed, the brand names are there. So people might be using a similar brand. They will know whether that product is, you know, present or not, and what the concentration or purity of that product is. It's quite a handy tool for engagement discussions. So being able to have that up, I guess we talk about, you know, culturally safe spaces and things like that for this particular group. I've said it at a few sort of things this year. You know, you can make things a safe space just by having the right posters or things up. And this is one of those things where I guess immediately, if I walked in and I saw someone had, you know, steroid checking trial results, wave 2, or whatever else, I'd think, oh, okay, like, it's all right. I can go in here and, you know, these people care about me. Might be able to offer me something. There's other resources there as well that are posted up. So extra harm reduction information that sort of encapsulates what people can do with the results, how they might modify their practices or change their usage, I think, which is pretty cool as well. And feel free to I guess, push people to those resources because I guess I wrote them and they're quite comprehensive in partnership with community, obviously. The other thing, and Sonia will talk a bit more about this, we have a health conversation that we've designed that sort of covers a few strategies. That conversation will be up on High Ground as well for everyone to see. But I'll let Sonia talk about that more because I feel like I've rambled enough. Women and steroids, rising prevalence, super high among subgroups like bodybuilders, and there's unique needs and strategies for them. So Sonia, tell me when you need me to change the slides, but all yours.
Thank you, Tim. And thank you for the information that you provided. I would just like to acknowledge the people of the lands on which I'm meeting, which is the Gubbi Gubbi Cubbi Cubbi people. And I will kick off. So as Tim has spoken about, the reason why people choose steroids is deeply personal. And Tim did touch on some reasons earlier, being aesthetics, well-being, performance, youthfulness, and mental health. I actually reached out to some friends who are currently using steroids within my own community, and I asked them, how do you believe that you are perceived by health workers and taking steroids? And this is why we're using Muscle Barbie and Muscle Ken, because this is how they believe that they are perceived, that they're using steroids to create this muscle hypertrophy, to have this big muscular look. I was really interested when my friend actually said to me, I want to remain competitive in the job market to the age of 67. And it was something I hadn't previously considered, but it is an important driving factor for this person, and I'm sure for many more, that as the retirement age gets pushed out, then we're expected to work longer and to have the strength that we need to do that. Sometimes this is why steroids become a chosen factor. Another reason, which is sometimes not understood, and something I will touch on a little bit more later, is the use of steroids to create an internalized sense of strength and power. And sometimes you won't actually look at that because, yes, we have this external look of a muscular physique, but it's for a much deeper reason. So I've just put in a couple more over here. Quicker recovery post-training, alleviate joint pain. You might be interested to learn that HIV, AIDS, and maintain muscle is still a reason why people are choosing steroids. Working within the industry as well, I have spoken to people living with HIV using steroids, and they do believe that HIV has negatively impacted upon their ability to produce testosterone. I don't have any facts or statistics to prove that point. It's just what a person actually feels based upon them living with HIV. Addressing body dysmorphia and that social media expectation of youthfulness. Next slide, please, Tim. So I want to quickly talk to steroids in women. For all persons using steroids, as I've said, is deeply personal, and it can sometimes be difficult to disentangle the reasons why men and why women actually use. I won't go into the reasons why because it's too vast, it's too broad, it's deeply personal. But since steroids and their use among women is still largely under-researched, especially with research more aligned to women using steroids for fitness, bodybuilding, and strength sports, it's really easy to overlook the deeper reasons behind the trend of women choosing steroids. And while the media often portrays women, like the one on the picture here, with increased muscle size, we also, which does emphasize motivations to enhancing performance and achieving a sense of elitism, there remains a risk of missing the more personal and internal stories that drive women to use steroids. And I think understanding these nuances is essential for a complete picture as to why women may be choosing steroids. As I kind of briefly touched on earlier, from my lived experience, I've recognized a deep desire for power and self-esteem after a deeply traumatic experience. And it's a journey many other women actually share. In a quest for internal strength, they're turning to steroids. So research conducted on women and steroid use actually highlights this same motivation linked to enhancing self-protection after trauma. And this drive for strength does more than just build muscle. As I previously said, it does create a profound sense of internal confidence, which I can confirm was created within me. For me, feeling strong in the gym translated into a powerful belief that I am strong and I can protect myself. And that was crucial to support me feeling safe within the world. So understanding women's motivations can create pathways for effective harm reduction conversations that are not just linked to sports, but are actually linked to an internal desire. So I guess the important note to remember is the why can sometimes be the same. However, women make up the minority of steroid users globally. And as such, further research is what we've said before, and harm reduction strategies specifically aligned to women does remain essential. Next slide, please, Tim. I really would, and Tim actually mentioned Anavar during his presentation, and I would like to bring your attention to this picture, which says Anavar for women. We see a woman with very low body fat, which is achieved through a combination of diet, exercise, and possibly the use of steroids. However, the headline under this woman is Anavar for women. And it's images like this that can spark curiosity among women, potentially driving them to seek Anavar for themselves. And often this means that women are more inclined to talk to men about accessing their steroids. Women may jump onto Google for dosage schedules, all in an effort to achieve this body that's before them without actually understanding the risks. I would also like to talk to when it comes to accessing steroids, whether it's for advice on steroids or guidance on dosages. As Tim said before, women represent 4% globally of the three. So Globally, 3.3% of people use. 4% is women, which makes us a minority. The further concerns to this for women is men typically have greater access to underground steroid sources. The reason I highlight that is that if women can't access it from an underground source, the availability of accessing steroids from a doctor is severely limited for women. Even though we may have done the research, we understand that we all decline in testosterone. We actually want to use testosterone. We want to use steroids or other performance and image enhancing drugs. We may not have access to that through legal channels. Hence, we're reliant on these underground markets, which men have got greater access to. Research has actually shown that women often face challenges in finding reliable suppliers, making them more vulnerable to unsafe products. Further research have expressed concerns that counterfeit and falsified compounds are particularly targeting women, which is a great concern because the reasons why is our own, and we're trying to access steroids, which will give us the benefit, but now we're being targeted because we're women and we may not have the same steroid literacy or the same access as what men do. So trusting the source alone for information carry serious long-term implications, some of which may be irreversible. Just in ending on that, I would like to say that for some women, especially in my case, in that I was pursuing empowerment because I wanted to feel strong, yet I was dependent on a man for the very substance I wanted for that sense of internal strength, which then created a power dynamic where to feel strong, I had to go to somebody else who held all the power with regards to steroid literacy, which I aligned my literacy to theirs. And then I also aligned my reliance on them to access the drugs that I wanted. And that power dynamic can be quite dangerous, especially if the person providing advice and providing the steroids aren't having the steroids tested, or they don't have a level of literacy needed to keep women safe. Just to really talk to some other implications, the long-term risks for women using steroids can include unwanted masculine traits, such as increased facial and body hair, changes in vocal tone. I'll refer to my own voice. As you can hear, it is a deepening female voice. It didn't always sound like this. I did actually have a high-pitched voice at one stage. So that change to my voice is ongoing, long-term. It will never change back. If I chose to go and have vocal surgery, maybe, but this is a voice that I will live with now. It can also result in a reduction in breast size, enlarged clitoris, irregular or absent menstruation, and decreased fertility. It really is crucial that women understand that excessive steroid use does lead to permanent virilization changes. And without surgery, be it breast augmentation or vocal surgery, this is what we actually live with. Very quickly, just want to talk to you if women are using steroids to manage perimenopausal or menopausal symptoms, as well as for general health and longevity. Should also consider speaking to an endocrinologist. So if they're coming to you for health advice, in place of just saying, no, you shouldn't do that, maybe ask them, have you spoken to an endocrinologist? Do you have a trusted GP that you can actually talk to about what you're wanting to get out of steroids? I'm aware of time, so I'm going to jump to my final point. From a personal experience, I recognize that an implication for me was that I seen these changes in my body and I felt the changes internally. So it was gaining that lean muscle. It was having this strength, and it was incredibly attractive. What this attractiveness brought to me was not wanting to take time off cycle, because I didn't want my body to change. I didn't want my strength to suffer. And so I wouldn't actually take time off. And if I did take time off, it was very limited. And that limited time off led to serious health concerns that weren't being monitored because I was deceptive with my GP. When I tried to talk about steroid use, I felt like I was chastised, I was judged, I was told no. I had increased hemoglobin levels, and then that was said to me that this is so dangerous. This is, you are going to create all these problems. So I decided to not talk about it at all and just kept on using. And then I suffered severe kidney failure. So there is a need for women to have a safe space to actually talk and be honest about our use, because that's what keeps us safe. Next slide, please, Tim. Very quickly, just some points to consider for all persons using PIEDs. Accessing steroids from a trusted source. Primarily, the most optimum would be a pharmacy. However, to access the amount that people are using for a cycle, you won't actually get that from a pharmacy. Have your steroids tested from a trusted facility. Get your blood work done, connect with trusted coaches, be aware of the risks, and really supporting the person to reflect on why they're choosing steroids, and really support them to be real and candid. What is it that you're actually wanting? And is steroids the best path to access that which you want? To always remember post-cycle recovery plan, to be aware, and steroids are not the magic pill. Strength training and a good diet are essential for results. Next slide, please, Tim. Thank you. So women's unique needs. I won't stay too long in here because I feel as though that we've covered a lot of what I wanted to say, but it's crucial for women to have a clear understanding of the substances they're using, to gain knowledge around their steroids, and to also feel confident to actually be attending checkpoint and having their steroids tested. That way they have the knowledge, they're aware of what's going into their body. They're no longer reliant on this trusted source going, no, I know what I'm doing, that's fine. Now they're actually really becoming educated. Having a safe space where women can talk openly and honestly. I think this is one of the most important factors, based upon my hiding my steroid use and then resulting in quite a significant health concern. Having a trusted person could actually result in having a harm reduction discussion, and then this person actually going and seeking further medical support. If they're told, no, that's wrong, like Tim said, it's going to disengage them almost immediately. And then their concerns will never actually come to the surface, and they could just keep on using and then have ongoing concerns. And maybe they don't want to have a voice like mine. And if they're not aware that this is a potential that could happen, then they may feel slighted by the health professionals that they've been speaking to, because they weren't honest about what could actually happen to them. Support to consider using steroids post-children based upon the known harm reduction to the harm to fertility issues related to steroid use, and being aware that needing time off cycle adds time on to allow hormones to settle, and be aware that what's going to happen when you come off, that your body fat levels will increase, they'll return to normal, and yes, your strength will decrease. Having that conversation and having a woman aware of that before it actually happens allows her to put in her own safety strategies to make sure that body dysmorphia isn't starting to creep up, that other health concerns aren't starting to impact upon them, and they've actually got a plan, because now they know what could potentially happen. Supporting women with the less is more principle. We're not just smaller versions of men. We have our own biological needs. I can say that during a cycle that I was taking far more than I needed. I was using multiple stacks. One included trenbolone, and I was like just a test bunny. just allowing myself to be tested, allowing myself to be overusing because I wasn't educating myself. So less is more is imperative, and being aware of the risks, I think, is really important. And Tim, the next slide, which I'll quickly run through, I was able to reach out to two persons in my personal world who are currently using steroids. One's a 33-year-old male, it's his first cycle. The second male is a 38-year-old long-term user who is now a strength and steroid coach. I just want to quickly go through their answers to the questions on the health questionnaire. I went into it very inquisitive, but this health survey really enlightened me as to the amount of information that we can access from a person and the harm reduction strategies that we can actually use. So both men confirmed to not having their steroids tested. A little bit concerning that the older gentleman, who's actually a steroid coach, was aware of the services, however, hadn't actually used them. So I really have encouraged him to use online services and also use Checkpoint, and advising him that it's accessible in Brisbane, which kind of opened up his world to making sure that he's having steroids tested before he uses them himself, and then also passing on that knowledge to others. First-time user had no idea that he could have his steroids tested, and he was reliant on a friend who had access to steroids from the gym, just taking his word for it. Steroid literacy, first-time user, no literacy at all, reliant on peers. The 38-year-old user actually said that at first he was reliant on peers, but then after an adverse personal experience, it really pushed into deep research before taking on another cycle. So really embedded himself deeply into that research. And I also gave him the resources from High Ground, which he'll now be actually using for the persons that he supports using steroids, which I think is fantastic. The health check, both males confirmed not having their health check at the beginning of each cycle. The 38-year-old now has a very trusted GP. The younger male, I talked about the risk to hemoglobin levels, which then sparked in his own memory that there is hemochromatosis in his family, then leading him to go, oh, I really need to take care of my health. I should really go and get tested. And that was through using the health conversation. I asked the questions exactly as they were, and it actually allowed him to identify his own needs and his own harm reduction strategies, because I didn't tell him. I just asked that question and allowed him to make up his own mind. Usage strategy, both males confirmed not having a usage strategy. Just being reliant on peers, I was able to then again refer them through to High Ground. Last one was experiencing distress. This was really interesting, and I didn't think of this before. They both said, the younger male said he had no concerns with his mental health, and he was surprised at being asked that question. I was able to let him know that, you know, changes and fluctuations in mood can actually happen, and then opened up my door and opened up my phone line to say, hey, if you're experiencing distress, please don't hesitate to reach out and give me a call. The 38-year-old user, this was interesting because I said to him, if I asked you this question before you first started using steroids, what would your answer be? He said, I probably wouldn't use them because I would be thinking about my mental health. Now, the reason for that is that this man had just come back from Afghanistan before taking on his first cycle and was experiencing post-traumatic stress. So asking that question can have real long-term positive implications for a person using. And I lied, I've got one more slide, which I've covered everything. I'm sorry, I'll be really quick. Just for harm reduction health workers to just be aware of the health conversation, please. It is amazing. Challenge your biases, adopt a bottom-up approach with us. Generally speaking, people who use steroids got a good understanding of our bodies. We don't necessarily understand the risks. understand that women have unique needs, engage with us, listen to our stories, and strive to understand our diverse and deeply personal reasons for using performance steroids, and discuss with us the harm reduction strategies found in the health conversation and meet us where we're at. Thank you for letting me go over time, and I do apologize. Thank you.
Thank you so much, both of you, Dr. Tim and Sonia. That was unbelievably amazing. We've had quite a few people thank you in the Q&A for your insights, and I also want to say thank you so much. That I think this has been really important information that people have gained from this, and it was just extremely generous of you to share your time, your knowledge, and your personal experience as well. We've had quite a few questions. Given that we are a little bit over time, I wonder if we could answer those questions through the website when we post this. I think some of them have probably been answered at least to some extent already, but if you're happy with that, we could do a Q&A section to go with this and answer the questions then. What do you reckon?
Up to you. We could do a bit of both. We could punch through a few now. We could do a FAQ. We could just do FAQ. Whatever. Yeah. I still got a bit of time, so
yeah,
great.
I have a bit of time as well.
All right. Well, let's do a couple of them, and hopefully the people who asked them are still there, and we'll still answer them later on, just in case the people have had to leave. I might start with the first question we got, which was about someone who works in an NSP and who felt that sometimes people who use steroids accessing the service may not be willing to listen to the harm reduction advice they were given by this person, or felt maybe they looked down on them as a different type of drug user. And so they were wondering if there's tips for how you might talk to these people.
I would say use the health conversation, just based upon my experience of actually using it. It was fantastic and did create that kind of open conversation. And the two persons I spoke to did not feel judged in any way. They were actually really happy to be asked those questions.
And we'll have a special section on high ground that will sort of come out like in the next little bit, but maybe you can help us promote as well. I think it's always a tricky one, like having that social like capital, and just being able to, you know, say I haven't used this drug, but like these things apply. I think it's that reframing the approach and like having that safe space there. Like I was talking to a few people from one of our services here in Queensland, and just having like posters about, I think we were talking about insulin at this particular time, and like how acknowledging that through visuals can create, you know, this idea that, you know, we care and we sort of can help you in certain ways, but also acknowledging that, you know, some people are perfectly happy with what they're doing and perfectly happy with the information source that they have, and just want to proceed and do that. And, you know, that's cool too.
Excellent points. I wonder if sometimes people are a bit embarrassed or something as well, and it comes across weirdly. So we had a couple of people also ask about the length of the needle, which I guess is probably the 25 gauge in particular, but maybe some other types of needles available. Do you know what length people should be recommending?
Yeah, so for say, if they look like we're going to call them experienced, Sonia, if they look like they're experienced, and they're shooting in their butt, in their glute, then 23 is cool all the way. And they're only shooting once a week. and they're just throwing like 2 mils in there or a mil in there. You want it deep in rather than towards the surface, because then I guess the risk is that it's not as smooth a release, right? Less smooth release equals less gains. I might have fluctuation in my hormone levels because that half-life can change depending on how deep you go. If they're shooting in their middle delt, they can do that with a 25 all day.
So a long 25 or 1 inch?
Yeah, again, if we're talking about an experience and they've got this half boulder sort of situation going on, that I sometimes reminisce about, then yeah. But I guess, you could go down to half or a quarter, like if, it's me, academic Tim, shoulder version, So always thinking about, I guess, how much fat tissue is sitting on it, and how lean they are, how big the muscle is, and what their sort of goal is. I don't want to overcomplicate it either. So if we just need like a blanket rule of 23 and 25, like that's cool.
Yep. And I can agree with that as well. So when I had shoulders that were, half a coconut, I was using that and then in my glute as well. So yeah.
And then, just not to be, if they've collected that knowledge from peers and they've got those recommendations, then there's a level of, they know what they might be using. I would immediately get concerned if they were like, I'm gonna shoot into my quad with a 20, not with a 31. Like that, then yeah, cool. Could probably say something.
Yeah.
So do you measure muscle size in coconuts? Is that the rule?
I like the coconut measure. I thought that was good. Yeah.
Excellent.
They're not that now. Like little peas.
We had a question about oil flow through the finer needles. Does that work?
Yeah. I mean, so you will, like, having done it, obviously, if it's a thick oil, and any of those longer esters, like if you get testosterone decanoate or DECA, nandrolone decanoate, sometimes the oil can be a little bit thicker. In Australia, up the top end, not really a problem. I guess bottom end, where it starts to get colder, could, like in winter, those oils get thick. I guess what I know some peers in Canada do is they'll chuck the oils in a pot on the stove, heat the oil up, and then get better flow that way. Not the most sanitary thing. What I would probably go with is this: if you're having issues pushing it through, that's okay. Just push it through slower, and don't try and push hard. Just recognize that you might be sitting there. If you're purposefully using, a 27 and you're sitting there with a thick oil, just know it might take you 3 minutes to get it all through, and that's okay. You just have to be there for that long. Push hard. And from personal experience, not only is it uncomfortable, but there's other weird and wonderful things that can happen when you push a piece of plastic really, really hard in different directions, and things can fall out of place and slip out and all kinds of things. So yeah, I think, or you just go up a gauge, right? And just, accept that you're gonna have to use the big needle.
And when I'm injecting my husband, I'll actually hold the barrel in my hand and just slowly, just kind of rub it between my hands just to get that little bit of warmth in, because that does actually support the flow. And then I'm not, trying to ram something in. It's It's a lot better process. It's less pain for him, and it's less pain for me trying to push something with my thumb into his butt.
Right. And you don't have to do the warming it up on a stove that's not as sterile and
That's not a good idea.
yeah, great. Okay. All right. Let's have one more about whether you can replace bacteriostatic water with the sterile injectable water that we often give out or supply in NSP.
I mean, I have, but look, I'm assuming this is for like peptide breakdown. So, I would, I guess, hardline recommendation is get the bacteriostatic water. If you're in a pinch, I guess, you know, you could, but is it the most sanitary way to do things? I mean, I think the stuff we've got in Queensland is usually we're talking about the 0.9% saline solution, I assume. Feel free to like shoot me an email about this, whoever you are, if you want. But I would I guess easy sort of hard line is just buy the Backstart water. It costs you like what, $9 for 10 mils or something like that. It'll last you for a while. It's not this is a cohort population group that is normally pretty cool with spending a couple bucks on the drugs and the related things that they need. So
that's right.
Yeah,
agreed.
Awesome. All right. Well, we might not take any more of your time and do the final questions over the next week or so.
Cool.
Thank you again so much for all of the information you've shared with us today, and it was outstanding. We will be in touch, and for everyone else, keep an eye on the AVIL website for the rest of your answers.
Thank you so much. Thank you.
Thanks, Sonia.
Big thanks to AVIL, Peer Power.
Big thanks to AVIL. Thank you.